Morning, everyone. I'm Max Michalski from Cedars-Sinai, as Glenn said. I'll be talking about Jones fractures, or fifth metatarsal base fractures. Is there a difference? What's in and what's out? I'd like to thank COA and Glenn for inviting me to take part in this session. Here are my disclosures. I think it's pretty safe to say that most people in the audience know the story of Jones twisting his own foot and being the first patient in his series of fifth metatarsal base fractures. I have the 6 images from the original paper, the first here being Jones's own foot. Unfortunately, it didn't, photograph or copy well over the years, so you can't even see the fracture line. But images 2 and 3 are typically what we consider a Jones fracture today. But why was this discovery important? It's because he was the first to describe this mechanism of fractures occurring without blunt trauma. It was indirect violence. But why was he able to be the first? Why did he publish this before anyone else? A lot of it comes down to timing and the fact that Jones was an early adopter. This is all relative to the relation of timing of the discovery of X-rays. Prior, if you felt the fifth metatarsal base fracture, there's not a lot of crepitus, so without X-ray, they weren't diagnosed. In December 1895, Röntgen described his new type of ray. This was then distributed around the world in January of 1896 by the London Standard. Less than a month later, Jones in his clinic saw a 12-year-old boy who presented having shot himself in the hand with a bullet. The bullet wasn't visible and it was lodged deep in the palmar arch. So Jones decided to experiment and took the kid to the lab with his assistant scientist, Oliver Lodge. And with just a mere 12 minutes of fluoroscopy, they were able to create this image. This is what is thought to be the first published clinical radiograph in the literature. But a lot of people think, well, he discovered that it was these are very difficult fractures, but it really wasn't. He was really important for noticing these fractures occur and their mechanism. It wasn't for another 20 years when Karp published a series of delayed unions of fifth metatarsal base fractures. So when did this term a Jones fracture come? In 1960, Clinical Orthopedics article by Stewart. He wrote up the paper calling these Jones fractures, describing this injury as Jones had originally described. He mentioned them as a fracture at the junction of the base and the shaft of the metatarsal. This correlates approximately to the distal extent of the 4-5 intermetatarsal articulation. He came up with one of the first classifications, describing them as either avulsion fractures or Jones fractures, with subgroups for comminution or articular involvement. He had his own classification system for treatment and a treatment algorithm suggesting conservative or symptomatic treatment for avulsion and comminution, and surgical treatment for Jones fractures or those with a large segment of joint involved. At the time, the proposed intervention was open reduction internal fixation with a nail gun, which I wish the 1960 X-rays photographed better. With further classifications came more confusion. In 1993, a foot fellow review by Lawrence and Bott came up with the classification most of us know today. They described tuberosity avulsion fractures, Jones fractures, and diaphyseal stress fractures, with these limits at the borders of the 4-5 intermetatarsal articulation. Unfortunately, they placed a junction right where a lot of these fractures occur. Actually, they put a junction right where Stewart described the fracture. Further, not all distal fractures are stress fractures. Adding to the confusion, 2 years later, a new classification came out with 3 zones by Damron in JAOS. Again, looking at this junction at the 4-5 articulation, but as you can see, hold on, these are similar, but they're definitely not the same. So within 2 years, we had 2 3-zone classification systems that came out, naming them essentially the same, but they actually follow different lines, and they are different. So anyone who finished training in the last 20 to 25 years, can remember seeing consults and being asked, well, what zone is it? And I can remember sitting back, I knew the classification, I just looked it up in my handbook of fractures, but I don't know what this is. It's on the border, it crosses the border. Or a lot of times you can't see the medial extent of the fracture line, so how do I know where it is in the 4-5 articulation? Given the confusion surrounding these zones, many have suggested decreasing it down to a 2-zone classification. In 2013, Polzer et al. Looked at a review of the evidence in the literature, and they found that based on the results, they thought there should only be 2 zones. They proposed this classification system with metaphyseal fractures and metadiaphyseal fractures. Their junction now occurs somewhere in the middle of zone 2. Admittedly, they said they aren't sure the exact location this belongs, but somewhere more proximal to the previous. With all these classifications, recently I want to know, is there any reliability to this? So I performed a study. I sent out a survey to the AOFAS email listserv. I had 230 fellowship-trained orthopedic foot and ankle surgeons respond. They were each sent 18 sets of x-rays of fifth metatarsal fractures. They were asked, is this a Jones fracture? What zone is this fracture? And assuming not many were familiar with the metaphyseal classification, I showed that system and asked them which one it is. Regarding the inter-rater reliability of the 230 surgeons, the Jones and zone only had moderate agreement, whereas the metaphyseal versus metadiaphyseal had substantial agreement. 80 surgeons then took the survey again, a total of 83 days later. The median kappa for the intra-rater reliability was the same for all systems. So what does this mean? Well, it means we disagree with each other when we're discussing what classification or what zone it is, but whatever definition we come up with, we can reproduce it. Then I asked each surgeon a series of 4 clinical questions. First, what do you consider a Jones fracture? And you can see there's a lot of variety in responses, and even 3 included zone 1. Do you treat patients, symptomatic patients in zones 2 and 3 in the same way? And 70% agreed yes. Then I was curious as to see who used what classification, and they were given these 2 images. 40% used that by Dameron, and 60% used that by Lawrence and Bott. And what I think is the most important question, that was a clinical related one, was which acute, non-displaced or minimally displaced fracture would you treat with operative fixation in a healthy active individual with no contraindications of surgery? I was surprised that 60% of foot and ankle surgeons operated on acute fractures that were Jones, zone 2, and zone 3. I can count on one finger how many of these I treated operatively during training. I always thought these were reserved for elite athletes, as Bob Anderson talked about, or these were for the general population after they failed conservative management. But is it just orthopedic dogma that the general population had to fail conservative management for surgery? Is there any literature to support this acute surgery? In a systematic review, including 630 fractures, 22 level 4, and 1 randomized control, they looked at outcomes of acute fractures and delayed fractures. Operative fixation had a 96% union rate versus 76% with non-operative treatment. This was emphasized more when you see, or magnified when you look at delayed unions with 97% operative union rate versus 40%. You need to take into account that negative outcomes are more rarely included in the literature, so I'm guessing that those non-operative numbers aren't as clear as what they would be. But an important point is that almost all conservative treatment options had weight bearing delayed for 6 to 8 weeks for non-operative treatment. Most of this is based on Torg's original data, who looked at a lot of these fifth metatarsal base fractures, and when he allowed weight bearing as tolerated, there was only a 40% union rate out of 10 patients, But if he kept them non-weight bearing in a cast for 6 weeks, there was a 93%. Another paper in support of acute management of these fractures was that by Portland et al. Instead of reserving these surgical treatment to the general population, they took all comers and operated on them with an intramedullary screw and allowed immediate weight bearing at their first post-operative visit 2 weeks later. They had a 100% union rate and a complication rate of 9%, with 2 prominent screws, one of which needed to be removed. So what is in, what is out? What's in? I think a surgical discussion for any patient who presents with a metadiaphyseal fracture should be offered surgery. The general population should be allowed earlier return to weight bearing and higher union rates if you believe in this literature. It should not be reserved for elite athletes, as we're all bipedal animals. We rely on 2 feet to get around and do our jobs. Next, 2 zones makes the most sense, as 70% of at least foot and ankle surgeons treat zones 2 and 3 the same. Further, it improves our reliability when communicating with each other in the literature. Now, what's out? This is not an anti-eponym crusade up here, but the use of the term Jones is confusing. It decreases your reliability, and similar is found with those with 3 zones. Thank you. We had some fun in the lazy river yesterday.